we have a tendency to complicate things. Yeah, you read through the textbook, and you read the positioning in the textbook, and it's really complicated, right? So it's step by step by step, and how to position and all that. And it's if you try to memorize the different steps in positioning, you're going to have a hard time. So I'm going to tell you the different things and the reason behind why we position the way we position. And that most of the positions that we use are really pretty logical. Some are a little bit inconvenient for the patient, but for the most part, logical from a physiological standpoint. Also, if you read through placement of your central array, it also seems pretty complicated, and it's not. It really is not. So I'm going to simplify most of your upper extremity central array locations in 3 minutes. Okay. So look at your hand. Okay. If you get an order for a hand x-ray, looking at your hand, what do you suppose you want to include on your hand? This is structure shown.
All
5 digits.
All 5 digits. You want to see the entire hand from the bottom of the hand up to the end of the fingers, right? So that's your structure shown. You want to see all 5 digits. And this gets a little bit complicated, but the function of your hand just doesn't work well without the wrist bones. So we're going to include the wrist bones all the way up to the distal portion of the radius and the ulna. Okay. So from here to here is what we're going to include for a hand x-ray. Okay. So if you tell your patient, I want you to put your hand on this, thing, and they put their hand out like this, how are their fingers most likely going to be? Slightly bent, right? It's most comfortable for them. That's an awkward position to be in. But if you flip the patient's hand around, what happens? It flattens out, right? So in that way, what position are we going to put the patient's hand in? This projection, you're going to struggle with that. That's okay. Prone, exactly. It's going to be pronated, PA projection. And where are you going to put your central ray? In a word, in the middle, right? So that's all you got to know is in the middle. And then you got to look at the anatomy and say, what is the middle of all that? All right. So looking at your hand, what's the middle of that? The base of the 3rd digit, that knuckle right there, right? So now you just got to identify that knuckle, right? And that's what we're going to do right now. So the names of all this stuff are a little bit complicated, but that's the positioning of your central ray, and also structure shown is the obvious things that are common to every exam type. You want to minimize superimposition. You want to not have artifacts. You want to make sure you include all the anatomy from top to bottom, left to right. So there's just structure shown. Where are you going to put the central ray? Middle of the anatomy. Now pick out the middle of the anatomy, right? It's really not rocket science, as long as you don't overcomplicate it and you just kind of look at it from a logical standpoint. The things aren't as complicated as what Merrill's makes it out to be. So, but we do have to know the technical names of everything. So what we've got in our fingers and hand, we've got phalanges, we've got metacarpals, and we've got carpal bones. Okay, so the phalanges are your fingers. Now you've got 5 fingers, right, including your thumb. You've got 5 fingers, and in each one of those fingers, except for the thumb, you have 4 individual pieces to them. All right, so then you got to identify exactly where those things are. So you got 4. We're going to leave the thumb out of this for now, but you've got 4 individual fingers, and you've got 3 portions of those fingers. You've got one at the end, one at the other end, and then one in the middle. Right? So what's the word that we use to describe something closest to the insertion? Proximal. Proximal. So we've got a proximal phalanx, we got a middle phalanx, and we've got the opposite of proximal is distal, right? So We've got 4 of those. So then we've got to identify which one's which. All right. So this always goes from anatomical position. Always goes from anatomical position. When does it go from anatomical position? Always, right. All right. And there's a reason I'm beating on that, and I'll tell you why here in a minute. All right. So anatomical position means patient's upright and their hands are, upright facing you, and the hands are essentially pronated. So they're upright and their palm of their hands are facing forward. All right. So our thumb is always going to be our first digit. All right. So we're going to get thumb in just a second, but our thumb's going to be our first digit. And then it's just from outer to inner, it's 1, 2, 3, 4, 5. Okay. So what if my hand's pronated? Which one's number 1? Still the thumb, because it's always from anatomical position, right? This didn't do anything to anatomical position. It's anatomical position is still like this. That's the lateral side. It's still the lateral side, even though looking at it, it looks like it's on the medial side. It's still the anatomy. It's the lateral side of the anatomy. Does that make sense? Okay. All right. So in the thumb, we only have 2. We've got the distal phalanx and we've got the proximal phalanx. That's it. We don't have 3. This is actually a metatarsal. So you got 5 digits. We've got 3 individual phalanx, or what's plural phalanx, in number 2 through 5, and then in the first one we only have 2. All right, and then we've got metacarpals. And metacarpals, they follow the same rule from the outside: 1, 2, 3, 4, 5. And then we've got the wrist bones, and we've got 8 individual wrist bones, and their names are going to be the trapezium, almost identical to that. We've got the trapezoid. We've got the capitate, which is the largest bone in the wrist, and it's pretty much dead square in the middle. And we've got a hamate, and then back over on the lateral side, in the proximal row on the lateral side, we've got the scaphoid. That's troublesome bone. Of the wrist bones, that's the one that's most commonly going to be broken. I've seen some of the other ones dislocated, never seen one of the other ones broken. So scaphoid, as far as wrist bones, actual wrist bones go, will be the most common, the one that is most commonly fractured. Then we've got the lunate, and we've got the tricatrum, and then we've got the pisiform. So lunate, we're going to use in our lateral positioning to determine whether or not we've got a good lateral position. Lunate, what does it sound like? The moon. The moon. It's going to look like a half moon or quarter moon, really, if you did a good lateral. Now, I said twice that the scaphoid is the most commonly broken wrist bone, but most of your wrist bones don't, or most of your wrist fractures don't involve the wrist bone. Most of your wrist fractures are going to be distal radius 9. Okay? But of those wrist bones, the scaphoid is most commonly fractured. All right? So we already talked about that. Articulation. Okay. So when we're trying to identify where to put our central ray, which number is this? 3rd. Right. So we've got articulations there as well. And we should have a laser pointer or something, but what we have here is a metacarpal, and that's a phalanx, right? So this would be the 5th metacarpal phalangeal joint. All right. So that's a phalanx, and that's a phalanx, which means that's going to be a interphalangeal joint. Okay, but which one is it? It's 5th. Right, still the 5th. That would be the proximal, so that would be the distal, right? So again, we've got the 4th. What is this here? Metacarpal phalangeal joint. Right? It's metacarpal phalangeal joint. That's metacarpal. That's a phalanx. It's a metacarpal phalangeal joint. That would be the proximal interphalangeal joint. Right. Now, where do you center your central ray for a hand? 3rd metacarpophalangeal joint. And on the test, you can probably check with your lab instructors, but you could probably abbreviate that. All right, MCP joint or MP joint, something like that. Right, instead of spelling that out, it's kind of awkward and long. Yeah. Oh, okay, okay. All right, all right. So you got that? Anybody need to go back through that again? Yes. Yes. Okay. Okay. What? Okay. The distal interphalangeal joint? Okay. Okay. So interphalangeal joint just means the joint between two individual phalanx, right? So this would be the proximal. Okay. So you just block off all this because this is the metacarpal phalangeal joint. So that will be your proximal and that will be your distal, right? So where I'm bending right there is your distal interphalangeal joint. Proximal interphalangeal joint, that will be your metacarpal phalangeal joint. Okay. Okay, so these are, things to help you remember the carpal bones. If they're helpful, then great. If not, then just memorize the bones. You might hear something else in clinicals. I'm not going to repeat it now, but you might hear something different in clinicals. It's a little racier, but I don't want to offend anybody, so just going to leave it off. All right. Let's get through. Okay, so general procedural guidelines. The things that you have to have on the image receptor and the things you don't want on the image receptor are going to be pretty much universal. So again, what we want presence of collimation, right? There's never a reason to shoot a hand on a 17 by 17 digital image receptor without collimations. Presence of collimation should be there. Lack of artifacts. If the patient's wearing a ring and the ring can come off, the ring needs to come off. Sometimes you're going to have a situation where the hand is swollen enough the ring won't come off, and that's fine. Also, sometimes you're going to have a situation where, if you take the brace off, the patient has cut through a minor artery or something in the fingers, and it'll start bleeding. So you got to be, aware of that. Make sure you don't, get hosed down. So sometimes you can't avoid having some sort of artifact, be it gauze or something like that. But if it can come off, you certainly want to have it come off. You want to have that stuff on the image receptor, the patient's name or identification number or both, the date of the exam, the hospital or the facility, and you also want to make sure that you have your marker on it as well, the correct marker. Now, some of your hospitals are going to be very, very particular about where they want their marker. They want it on the lateral side, so that would be the thumb side. Thumb side's always going to be the lateral side. So they want it on the lateral side, a specific place, specific markers, oriented in a specific way. So you're going to have to kind of make adjustments and learn what it is that the radiologist wants. So all of that stuff is common to all the x-rays that we're going to do. I'm not going to cover that for every one we do. It's assumed that you don't want artifacts and you want to include all the anatomy, but you want to collimate. I am going to talk about collimation in context of the things that you're probably going to have a tendency to overlook and the ways that you might not include the anatomy of interest. So I will talk more about collimations, but that's all that stuff there. Artifacts, ambulatory patients. So if you're doing an exam on a patient, let's say an ER patient, and they're on a stretcher, my recommendation is to move the patient as little as possible. If you're doing fingers on a patient and they're an ER patient and they're on a stretcher, is there really any reason to get them off of that stretcher, put them onto the x-ray table and position them on the x-ray table? And the answer is no, there's not really. Make it easy on the patient. Just do the exam, on the stretcher. You could even take a portable over and do the exam portable. It's fundamentally the same thing. You're you got your image receptor that you're going to put the patient's anatomy directly on, and then you're going to adjust the X-ray tube directly over the patient. Fundamentally the same thing. You're not really going to get a better X-ray in the department than what you would get portable. So make it as easy on the patient as possible. If the patient is what we refer to as a walkie-talkie patient, and they walked into the hospital. If they're an outpatient, okay, well then those patients you bring back. But do you need to put the patient on the table for a hand? Answer is no. Put them in a chair, right? Make them comfortable, and least amount of motion, least amount of movement, least amount of climbing, the better. All right. So again, we'll talk about collimation as we go through. SID, for the most part, that's your source to image receptor distance, how far the tube is away from the patient, is pretty much on almost all of your upper extremity work going to be 40 inches. I'm going to tell you when we're going to get to 72 inches. Okay, and that's not until we get to the shoulder. All right, so now, how many times you got to read through SID in your Merrills for your upper extremity work? Once, yeah. For the shoulder projections, I'm going to talk about later. Right, so that's taken care of. Right, don't have to worry about that. 40 inches, no reason to use any more than that. Make sure you use your markers. Radiation protection primarily is going to be your collimation. So I think most of our hospitals are still tend to shield the patient, right? So still tend to put an X-ray gown on the patient. I think that's still protocol, but industry standards are kind of making a shift, and I expect that the recommendation for shielding is going to go away in most cases. As research comes out, I really kind of expect it to go away. So you're going to have to make an adjustment for that, but for now, follow your hospital protocol. It's not going to do you any good to argue with doctors and administrators. Well, the ART says not to shield. Well, your boss is telling you to shield. So, shield. So follow hospital protocol. Your breathing instructions, you're not going to have breathing instructions for your extremity work again until we get to the shoulder. So you might be working with somebody who, you wrote her up, you're doing a hand on an X-ray, a hand on a patient, and they tell you, lean over right before you make your exposure and say, hold your breath. They're just messing with you, I used to do that all the time. It was hilarious because as soon as they say, hold your breath, make the exposure, and then really, it's hilarious. It really is. But they're just messing with you. You don't have to have the patient hold breath for him. All right, so essential projections. What we're going to talk about for the fingers, the hand, the wrist, and if we get to the elbow, we'll talk about elbow, is going to be PA lateral and obliques. And the obliques might not always be PA oblique. For the hand and the wrist, for the most part, it's going to be. But when we get to the elbow, it's going to be AP oblique. Now, let's simplify this. Every oblique that we're going to talk about until I tell you otherwise is going to be 45 degrees. 45 degrees. How many degrees? 45. Every single one of them until I tell you otherwise. Okay, everyone's going to be 45 degrees. So we're going to talk about PA, we're going to talk about lateral, and then we're going to have some variations on the oblique, but the degree of oblique is always going to be 45 degrees, exactly. All right, so collimation, central ray. Okay, so something else you're going to have a tendency to kind of confuse is perpendicularity and parallel relationships. Okay, so in the position of your central ray, our central ray for our hand, for example, is going to be to the third metacarpal phalangeal joint. It's going to be perpendicular to the anatomy, right? But in order to see through a joint space, I really should let's pretend. Okay. Can't see a joint space. All right. can you see the light between the distal portion of the humerus and the radial head?
Yes.
Okay. You can see that because the light is parallel to the joint space. All right. The projector is perpendicular to the anatomy. Okay. Can you kind of tie those two together? So in our hand, our central ray is going to be perpendicular to that knuckle, right? But in order to see that open joint space, it has to be parallel to the joint space. Okay, to the space. To the anatomy, it's perpendicular. To the space, it's got to be parallel. Otherwise, if it's not parallel, then well, you can see it better there. Let's go this way. Can you see it now? The answer is no. You can't because it's not parallel to the joint space. Okay? To see the open joint space, the central ray has to be parallel to the joint space. Perpendicular to the anatomy, but parallel to the joint space. For individual fingers, all right, so we're doing individual fingers first. So for individual fingers, again, what we want to see is we want to see the entire digit. So let's say we're taking an x-ray of this digit. What is that? The second is my left second finger, right? So what's the center point of my left second finger?
It's a long word.
A long word. Very good. Very good. It's the metacarpophalangeal, or I'm sorry, metacarpophalangeal joint there. Our proximal interphalangeal joint, right? Now, for every anatomy that we see, especially in bones, what we have to see is we have to see the adjacent anatomy. All right. So we don't see the entire finger unless we see the distal portion of the metacarpal. Okay. So we have to see the distal portion of the metacarpal all the way out to the distal portion of the finger. Okay. So if I put my central ray there and I open up my collimation to extend to the distal portion of the metacarpal, am I going to see the distal portion of the finger? And the answer is yeah. Yeah. Okay, so our PA projection of the finger, central ray is going to be to that knuckle. Open your collimation up enough that it includes the distal portion of the metacarpal. Some of your hospitals will expect you to shoot adjacent digits, especially in kids, so that they can compare growth plates. Some of your hospitals, if they have kids, want to see the same digit on the opposite hand, right? And it's not just fingers. This is any extremity work. If we're doing wrists, for example, to make sure that there's not a potential fracture through the epiphyseal plate, they'll want what we refer to as comparison groups. Okay, so in the fingers, they're all the same. Our central ray is going to be to the proximal interphalangeal joint. For all of our PA, it's going to be PA projection. All right, so for all four of those fingers, and I'm still leaving the thumb out because it's got its own special thing going on, but that's going to be your positioning. All right, so our obliques, though, are going to be what kind of degrees? 45. And the direction that we're going to oblique depends on the finger itself. Okay. Full disclosure, it doesn't really matter, if you're in a pinch, which way you go with it. But for textbook purposes and for testing purposes, it does. Okay. So for these two, right, for fourth and fifth, then what we want to rotate towards is the lateral side. Now, why is that? Bingo. We reduce our OID, our object image distance, and we keep the anatomy closer to the image receptor, thereby increasing sharpness of recorded detail. If we're doing number 2 and 3, we're going to rotate this direction for the same reason. You may have to tuck your thumb in order to make that happen, but we're going to rotate. In this case, that will be towards the lateral side. I think I said it's rotation laterally, but it's towards medial side. So I would rotate with these two digits closest to the image receptor. So for the same reason, reduce OID, increase sharpness, recorded detail. Lateral is the same way. Lateral is going to be true lateral. And you might have some difficulty getting the fingers bent so that you can see the individual fingers. So the textbook recommends you take maybe a tongue depressor, like if maybe you need to see the ring finger, take the tongue depressor and push it like that. So if you've got a broken finger and somebody's asking you to, push a finger like that, what's your answer? Yeah, get bent, right? So no, I'm not. But you can do other things. You can extend your pinky finger and it'll kind of drag that finger with it, right? So you can do other things to make it, make it happen. But the rotation in which lateral we do, whether it be medial side down or lateral side down, is also going to be dependent on which finger we're shooting. So if we're shooting numbers 4 and 5, we're going to go with the lateral side down. If we're shooting 2 and 3, we're going to go with medial side down. Right? Okay. So the thumb, though, presents some specific challenges. Number one, the thumb is the only finger that we're going to shoot and include the entire metacarpal. Okay. So all the other ones, we just need to see the distal portion of the metacarpal. With the thumb, we need to see the whole thing. And that's because we've got an opposable thumb. The whole thing acts like a thumb. Some of our more common thumb fractures are not of the thumb itself, but of the finger portion of the thumb, but of the metacarpal. Anybody ever been snow skiing? Okay. So you're buzzing down the hill real good, and something happens and you're about to wipe out and you jam your ski poles into the ground, and you do wipe out, and you come back up. Where's your hand hurt sometimes? Right there, ski pole injury. There's a specific fracture that we call a Bennett's fracture, and it's caused by, and it's also referred to as ski pole injury, but it's caused by probably extension of the thumb, and it's a fracture of the base of the first metacarpal. Okay, so it's technically a thumb fracture, even though the thumb's not involved at all. It's the metacarpal. So we're going to look at the entire thing. So number one, it's the only finger that we're going to shoot to include the entire metacarpal. That's number one. So then our central ray becomes to the metacarpal phalangeal joint for the first digit. Only one that we're going to use, metacarpal phalangeal joint. Include the entire metacarpal. That's number one. Number two is that if I put my hand flat like that, what position is my thumb in? Not projection. It's kind of oblique, right? It's kind of oblique. It's not really lateral. It's certainly not prone. It's kind of oblique. So what position is your hand in to get a good oblique of the thumb? We're back to, he did it again. Prone. Back to prone, right? Y'all are going to trip over AP, projection versus position, probably for 2 semesters. Okay, so just get used to it. I'm going to bust on you a little bit when you do. It's just the way it is. So prone, and truth be known, I'm going to trip over it too. And y'all are free to fire back at me. So prone, for oblique of the thumb, we're going to go with prone position. Okay. So how do we get it into a lateral position then? We'll turn it. Yeah, turn it. So all we have to do then is to bend the fingers up, and it'll just roll it into a natural oblique or natural lateral. Okay, just bend the fingers up, but we still have a problem with the PA. So how are we going to get a PA in the thumb? I'll give you a hint. We're not. Bingo. We're going to get AP. In order to get a good PA, we got to do this. Right? What's the problem here? OID. Yeah. So we've got an enormous OID there. So what we're going to do is we're going to do AP. So however you've got to position the patient to get their thumb like that, go for it. So you can go like that, so you can rotate around like this. The problem with this is you're going to have to watch out for the rest of the hand. Okay, so if you internally rotate the arm like that, and you don't get the rest of the hand out of the way, then you're going to have the rest of the hand over the metacarpal. Yeah. All right. So make sure that if you're going to internally rotate, then you internally rotate everything. Right. Or you can just do it like that. Whatever you got to do. I've seen people, tape. This was back when we used to use films. Tape a film to the wall bucky and have a patient stand up here like this. Whatever you got to do, it doesn't matter. Just get it into an AP, include the entire metacarpal without superimposition of the rest of the hand. Okay. So that's all your fingers. Any question on fingers? How bad am I on time?
57.
Oh, 37. I thought you said 57. Yeah. All right. So my purpose in this is to try to get enough for them to cover in lab. Okay, so that's fingers. Any question on fingers? Okay, well, hands, really pretty much same thing. The hand, we're going to put the hand prone, so we're going to shoot a PA projection, right? In our central ray, again, we've already covered that. It's going to be to the third metacarpal phalangeal joint. Make sure that you get your fingers flat. If the fingers are bent, then we're back to this situation where we're not going to be able to see the joint spaces, right? It's going to close up the joint spaces because the central ray can't be parallel joint spaces if the fingers are bent. Also, in your collimation, in your positioning, what you're probably going to do is tell the patient, I want you to put your hand on this thing, right? So the patient puts their hand like this, and you're going to be so laser focused on that central ray location, and the thought that you've got to get collimation, you're going to get collimation to a half an inch there. You're going to include the carpal bones, the distal portion of the radius and the ulna. You're going to make sure that your pinky's on there, and you're going to collimate down to this. And you're going to clip the thumb. Okay, so make sure that you consider the thumb too, and make sure it's in the light as well, even if you have to bring it in a little bit. That's what we refer to as adduction. Abduction means taking away, right? And adduction means to bring it back in. Don't adduct it to this point, but you can bring it in a little bit and make sure that you don't clip it. Okay. Probably the most common first semester positioning error of hands that I ever saw when I was clinical instructor or working on the clinical side. Okay, so that's PA. Oblique of the hand, we have two options for the oblique of the hand. And it depends on really what you're looking for and what hospital protocol is. So one is to have the patient use their fingers and just keep the pinky finger straight, but bend the rest of the fingers up. So to have the patient, kind of like make an OK sign and rotate the fingers up to where the distal portion of the fingers are still on the image receptor. Okay. And a lot of hospitals, a lot of doctors are perfectly fine with this. Just know that if you do this, what kind of problems do you potentially see here? Okay, a little bit of overlap, a little bit of superimposition. Patient might get their fingers all jammed together like that, right? And kind of distort the thumb and the forefinger. But what are you not going to see on anything except for the pinky finger? Joint spaces. Exactly. You're not going to see joint spaces. Right? So, if your doctor's okay with that and your hospital's okay with that, then, follow protocol. It's a little bit easier, but just know that you're not going to see joint spaces. They're going to be closed because they're at an angle. They're not parallel to the central ray. The other option is what we refer to as a fan or an oblique. It is a fan, but we usually refer to that in the lateral. But to keep the fingers parallel to the image receptor keeps the joint spaces perpendicular and therefore parallel to the central ray. and we can see the joint spaces if we stretch fingers out. Okay, so whichever one your hospital goes with is fine. Doesn't really matter. In both cases, what's our degree of obliquity? 45. Exactly. So then our lateral kind of follows the same trend. So if you're doing your oblique where the fingers are parallel to the image receptor, you can just rotate the fingers up. And you're probably going to have some superimposition, especially on the proximal end, but this is what we refer to as a fan lateral. Okay, so fan lateral, for obvious reasons, the fingers are fanned out, right? So where this the application where this is best is where the patient might have potential fractures in the individual fingers. Okay, so if a patient has a potential fracture in one of the digits, then this is preferred. If the patient, though, has a foreign body, which is not uncommon, especially in people who work with like metals and things like that, they get metal fragments in their hands. All right, so if you then have a metal fragment in the hand and you have your fingers all fanned out like that, it just gets swallowed up, right? And you can't really tell exactly where it is. As opposed to if we just have the fingers straight like that with the thumb out of the way, we get a better idea of where that metal fragment might be. Okay, so this is what we refer to as a lateral in extension. And again, some of your hospitals, this will be your protocol, even if the patient has broken fingers. Just know that you're going to have superimposition of the digits, each one of the digits, if this is your protocol and this is what you choose to do. Okay? So, what is this best for? Foreign bodies as opposed to broken fingers, right? Okay? So any questions on fingers or hands or thumbs? Okay, so there's your Bennett fracture I was talking about before. It's a Bennett fracture. Little right there. So other things that you see in the hands, you got osteoarthritis. That's just normal wear and tear. The articular ends of the bones tend to get a little bit brighter. Rheumatoid arthritis is something totally different. The articular ends get eaten away, and the bones themselves take on an appearance more like the patient has osteoporosis. Okay, so hands. All right, so wrist. All right, so what's my time looking like? I got enough time for wrist, and that's about it. Okay, so wrist. Our wrist is going to be our first thing that we're going to shoot with kind of complicated positioning of the rest of the anatomy. This doesn't come out of the Merrills. This comes out of a textbook that you're going to use in your sophomore year. Okay, so what we're going to do with the wrist is we're going to take all the upper extremity and put it in the same plane. It's still going to be PA projection. So we're going to do PA projection, but we're going to put everything in the same plane. So what I want you to do first is to put your hand on your desk and feel for your styloid process that we were talking about before. Okay, so your evaluation criteria in your Merrills is for the ulnar styloid process to be in profile. All right, so you think of profile, what do you think of? All right, profile. So if you keep your finger on your radial styloid process, or your ulnar styloid process, and you elevate that up to the shoulder level, tell me what happens. It goes away, right? So keep your arm bent at 90 degrees. I kind of missed that. So keep your arm bent at 90 degrees and mash on it and raise it up to the shoulder level. It's kind of freaky, isn't it? So if it's poking out the back, you're never going to see it in profile. So what you have to do is you have to get your shoulder, your elbow, and your wrist all in the same plane. Okay? So get it all in the same plane. What that might involve is you may have to have a patient sitting in a stool and kind of sitting on a stool and kind of slouching over in order to get them all in the same plane. The other thing that you need to do is take the fingers and bend the fingers up. Shut up on my phone. This is image receptor now. All right. So if I take and I put my hand flat,
You want my book?
yeah, I do. I want to go commandeer somebody's book there. All right. If this is image receptor, it's not a book. All right. So if I take my hand and I put it flat on the book, the image receptor, look what happens. Can you see the gap there? Can y'all see over here? Can you see the gap between my wrist and the book? And I just kind of gave away what I want you to do. Can you see it right there? Can anybody not? Every time I move, every time I look at y'all, I lose it. Can you see what I'm talking about? Where the light's going under my wrist. Okay. All right. So what is that? If this is our image receptor, my object is my wrist. That's an increase in OID, right? So what does an increase in OID give us? Magnification, loss, sharpness, of recorded detail, right? So watch what happens now. All right. So my fingers, if I bend my fingers up, what happened? It went away, right? So what you need to do for a PA projection of the wrist is get all three of those things the same plane, have the patient bend their fingers up, don't have them clench their fist, but have them bring their fingers up so that it puts the wrist bones closest to the image receptor. Okay, so just bend them up a little bit until that gap disappears. Okay, that's your PA projection. Most of your wrist fractures are going to be your distal radius and ulna. So what you want to include is about a third of the radius and the ulna. That's going to give you about a half of the hand too. Okay, central ray is going to be right to the middle of the wrist bones. All right, our oblique of the wrist is going to be external rotation. All right, so we're going to take from that, we're going to externally rotate the patient's wrist for what degree? 45 degrees, exactly. So what the oblique of the wrist is going to show us is our scaphoid, which is our most commonly fractured wrist bone. And our scaphoid is at a natural angulation to the image receptor. So if it breaks down here, then the fracture line is going to be an angle to the central ray. We're not going to see it very well, right? So if it's at an angle, we've got distortion. Distortion is misrepresentation of the anatomy. Good representation of the anatomy, not good representation of the anatomy. Distortion. That's what we refer to as foreshortening. Okay? So anytime we have anatomy at an angle to the image receptor, then we have foreshortening. Sorry?
It's not good.
Okay. I'll finish with this. And then I'm going to get in trouble because I didn't cover it. All right, so our oblique, thank you very much. Our oblique takes our scaphoid and it puts it more parallel to the image receptor. So it takes the bone that we break most commonly in the wrist and it puts it more parallel to the image receptor. So we don't have that foreshortening and distortion of the anatomy. We can see it better. More likely to be able to make that diagnosis. Okay? 45 degrees. I can't help myself. I've got to finish wrist. One other thing. Our lateral. Okay. Our lateral. We got to bring it all the way up to a lateral as well. So 3 views. We got our PA. We've got our oblique, 45-degree oblique, and our lateral. It would seem like all we had to do was to take the hand and put it lateral to get a lateral of the wrist, right? It can be, quite that simple. Now, I want you to feel of your hand and feel where that ulnar styloid process is now. Where is it? It's kind of out back, isn't it? You've also got a radial styloid process, and that's that bump that is kind of on the front. Your evaluation criteria in your Merrill's says that those two need to be superimposed or stacked on top of themselves. So if your hand is straight up and down like that, are they going to be stacked? The answer is no. And this is not in Merrill's. This is not in any positioning book that you're going to find. But you're going to get a better lateral if you slightly supinate the hand. And when I say slightly supinate, I'm talking about you got lateral, you got slight supination. 5 degrees. Okay? It's very minimal. But what that does is it makes the radial styloid process go that way, it makes the ulnar styloid process come this way. They get superimposed. You get a better lateral wrist. Okay? Now I'm done. All right, any questions? We got a lot to cover in upper extremity. Remember, only study what we cover. Because if you've been through upper extremity, there's 100 pages and 50 of those are things you don't need to know. Okay? Don't waste your time. If you read Bouchon's little penguin thing, anybody read that? Yeah. Those penguins you don't need.